Welcome back, guys. Welcome back. Now, at this point and for the rest of the semester, we're going to focus exclusively on psychological disorders. And we're going to begin our conversation on psychological disorders with anxiety disorders. Before we go into the actual topic, there's a couple last things that I do need to address. One is, overall, all psychological disorders that we are learning about from this class are going to be straight out coming out from the DSM. So the Diagnostic Statistical Manual is the clinical book that we use to guide ourselves in the symptoms, characteristics, and proper diagnosis of the disorder. We're currently in the 5th edition that was published in 2013. So according to the DSM in the 5th edition, those are some of the most common anxiety disorders. Not all anxiety disorders will be covered in this video or in this class, mostly because it's going to take us a long time, so I'm just going to walk you through the whole thing. But before that, you got to understand that psychological disorders have categories. So there's a category that encompasses a group of psychological disorders because they have one thing in common. Those are called anxiety because all the different disorders have anxiety in common. And that's going to happen as we move forward to the next disorders that we'll learn about. So the mood disorders, they all have in common that is shifting the mood. The psychotic disorders, they all have in common that is psychosis, and so on and so on. So for anxiety disorders, not all, but almost all disorders that are within one category, they have in common the genetic disposition, predisposition. So there's a genetic vulnerability. And anxiety is one of those disorders that have a genetic vulnerability, so it can be passed down from families. From families genetically. When you do a clinical assessment, typically, not always, but typically you do ask about family history. And I remember in my experience working in the field, how sometimes the patients would ask, what's the point of this? Why do you need to learn about my family? And it's funny because I would question the same thing. Yeah, why am I asking them about their family? Because I was doing a clinical assessment that was given to me by the psychiatric hospital where I was working. And it's because we're trying to learn, and I realized this later on, we're trying to learn what kind of characteristics exist perhaps in the family to understand how the disorder may be partially genetic. Not in all disorders, but at least, for example, in anxiety disorders, there is a genetic component. Now, this doesn't mean that if there's a predisposition for anxiety disorders, it doesn't mean that it will spread out to everyone in the family, no. But some people may have a genetic predisposition to fall for anxiety disorders. And I ask you this, think about your family. Maybe in your family there is a genetic predisposition for something. If in your family there's a history of a specific mental illness, it's not a coincidence, it's probably because there's a genetic trait that is being passed down. So if your grandparents had it, if your parents had it, maybe you have it, well, your kids are gonna maybe have it. This is when the environment then comes in and you gotta realize, well, what kind of things could I be doing to protect myself or my kids or my parents from this coming back to haunt them. So it's important to know the family history, and it's important to know the genetic predisposition that could exist out there. Now, one more comment on that. It may be passed down, but maybe in your family history, there's no official diagnosis because your family doesn't really believe in mental illness or psychiatry. So no one in your family has been diagnosed with it, but this wouldn't mean that it's not there. It's possibly, maybe it's there, but it's just not diagnosed because nobody has sought clinical help. You know what I mean? In my family, there is no diagnosable psychiatric condition on my mother's side of the family. But it's very obvious that there are some clinical problems there, but they were not given a diagnosis because they didn't look for that specific help. This may be common in some cultures. So for example, in Hispanic culture, sometimes instead of going to a psychiatrist to treat a problem that you may have, or even to go see a counselor or a clinician for anything that is even outpatient, something like dealing with a minor depression, instead of going out to the psychologist, to the counselor, to the clinician, maybe the family is going to say, go talk to the church leader, go talk to the priest. And that's, respectable, that's fine. But again, maybe they're given a type of therapy that resembles what we do here as professionals, and maybe that help is enough to get a person feeling better. But even if there was not a name for a diagnosis, it doesn't mean that the disorder wasn't there. So I want to bring that point out because genetically there may be a predisposition, and if you say, well, in my family nobody has been diagnosed with a mental problem, it doesn't mean that it's not there. Maybe that you never sought that help in the family, but it doesn't mean that it's going to shield you from it. Maybe you're going to be the one that's going to be experiencing this. This applies to you, and this can apply to any client or patient that you may have in the future. Lastly, I do want to emphasize the point of comorbidity. So, comorbidity is a term that explains how sometimes there may be more than one disorder within one person. So, comorbidity is having more than one disorder, so multiple disorders. And you may see very severe cases when you have comorbidity of 2, 3, 4 disorders in one person. So the more disorders you have within the person, the more difficult the case, the more complex the case becomes. Well, let's talk about one last thing. Within the categories, it's more likely that you're going to see comorbidity in those disorders. So for example, if there's a genetic predisposition for anxiety, the person may meet the criteria for generalized anxiety disorder, and is not unique to that. Perhaps the person may also develop comorbidity to not only have generalized anxiety disorder, but also phobias. So the person that not only struggles with overwhelming levels of anxiety, but is also specifically experiencing severe anxiety to a specific event or a specific thing. Phobias can be somewhat common, but if it's not something that you encounter often, maybe you don't really get to experience that sense of a phobia that often. I believe that I have a diagnosable condition for what meets the criteria of a phobia to snakes. I am very much horrified and deeply anxious when I encounter something that has to do with snakes on TV, in a movie, when I go to the zoo, or so on. Rarely in my life have I ever encountered a live snake, but I have in front of me, and the way that I freeze and the way that I feel is not normal. But in my real life, I don't really deal with snakes that often. So it's not really much of a problem because it's not creating a dysfunction in my day-to-day life. If on the other hand, say that I have a specific type of phobia to anything really, say that I have a specific type of phobia to speaking in public, and I'm trying to have a profession as a professor, that's going to be very difficult if I try to make myself get a living encountering the phobia that I have over and over and over again. So the way that phobias dysfunction or disrupt someone's life varies a lot. So that's the thing with phobias. The anxiety may be specifically building in the person by some specific circumstances. Generalized anxiety disorder is at the level of anxiety that anybody can experience, but to the point that it's dysfunctional. Anybody can experience anxiety, but for some people the level of anxiety can be so overwhelming that it's just impossible to have a normal life. That's generalized anxiety disorder. You see there obsessive compulsive disorder. Obsessive compulsive disorder refers to two traits, which is obsessions, which is the thoughts that are overwhelming the person, and compulsions is the ongoing behaviors that a person must experience, or else the anxiety is going to eat them up. Quick story. Case study. Encounter one time a lady who would have to check the doors and the drawers to make sure that everything was closed properly before she left the house. And it was a routine that was kind of common for her. She would go around, make sure that everything is locked, make sure that everything is closed. And she would do this as she grew older. This would become worse and worse and worse to the point that she wasn't happy with doing it once, or not happy, but I mean, overall just calm with doing it one time, but you would have to do it over and over and over several times. She was married. Her husband was at the point that if they were going out, leaving the house, he knew that he would go to the car, like turn on the car, and he had to wait in the car for at least 30 minutes because the woman, the wife, would have to be around doing this routine. He kind of left, he had kind of lived and like being with it for a while, and he kind of like just acknowledged and lived with it. But as the years went by, this became worse and worse and worse, which is actually a characteristic of OCD. It tends to worsen with age. So it wasn't enough with 30 minutes. It built up to an hour. It went out to the point where if they were going to leave the house, she would have to spend like 2 hours making sure that everything was like that. One day, she feels the routine, she feels calm, she leaves, and the husband is no longer there. I don't remember if he left a note or if he texted her afterwards. I don't remember. But the point is, the husband left and just eventually told her, I can't do this anymore. She was heartbroken. At that point, she realized she had a problem. They had been with this for years, but she didn't realize that she had a problem until it disrupted her life because it affected her marriage. At that point, then she came into the hospital to seek help. The dysfunction can hit us at different points. Lastly, social anxiety disorder. And social anxiety disorder, again, built up from the moment, and it's almost like a type of phobia, but it's so common that it brings a different, unique, distinctive definition. And again, these are not the only type of anxiety disorders. There's a multitude of them, and they may be reflected in different ways. You may have people that are pulling their hair. You may have people that are picking on their skin. You may have people that are doing habits like scratching themselves. You may have people that experience panic disorders. Like, there's a bunch of different ways. So if there's a genetic history of anxiety and you have 3 family members, maybe one person is going to experience anxiety disorder, another person may experience a type of OCD, and another person may experience a phobia. All 3 have anxiety, but it may affect them in different ways. Or maybe you have a person that can experience all 3 disorders because they are comorbid. And you may have a person that the environment is not bad for them and they never experience anything. So it varies a lot. This is to the point where you understand how anxiety disorders work. Alright? Nice introduction. Everything else, go through the slides. Make sure that you read the book chapter, and if you have any questions, come back with me. Alright?